Link. So just to kind of get rolling. Oh, and at the end of this, we do have a poll. So everybody can say if this is going to be a high priority um, or a low priority within their own agency. Jamie, do you have anything else to add to that, or?
I just want folks to understand the relationship between the Alliance and LMHPCO. LMHPCO is a 501c3, and we are very limited as a C3 in doing lobbying and advocacy. So about 10 years ago, LMHPCO formed a C4, 501c4, which can do lobbying, and so it is a separate organization, has a different board of directors than LMHPCO board of directors. LMHPCO board of directors assigns or appoints the board members to the alliance, and those appointments are usually based upon folks' contributions to the alliance. So if you want to become a member of the board of directors for the alliance, I highly encourage you to make a contribution to the work of the alliance, and the LMHPCO board of directors will consider your contribution and put you on the alliance board. And so the process that we're doing is we're doing a series of listening sessions today, and then I think we're going to repeat this next week, either with new folks, or if the topics today prove to be things that we need to discuss more, we will use next week's session to continue that discussion. So it all depends what today's session goes like. Um, and
And then there's separate Mississippi sessions as
then there'll
well.
be separate Mississippi listening sessions. And then we take all of these notes and we're going to bring them to the board of directors. And if you want to see who's the board of directors, you can go to our website, and go to the alliance page and then look at the board of directors, and we'll take all of your thoughts and your issues or that we bring up here to those board members for them to decide how we're going to actually strategize and get these things accomplished. So anyone have any questions about process or the alliance?
And in the chat right now, I am putting my email and phone number as well.
Well, Elizabeth, you
Right.
want to start talking about some of the issues that
Yeah,
came up at the conference that we are going to be discussing today?
yeah. So we'll start with the first one that I have on my list, which I think was on the same order as the general list, but I might be wrong on that. The pronouncement of death. We have had quite a few agencies, I would say, that are starting to have issues during their surveys. In particular, we had one agency that an RN said that she was the one that pronounced the death, which is not legal in the state of Louisiana. And so we're trying to figure out if there's been a number of agencies that have had issues in surveys with this, or if you're having issues with your coroner. We've also heard that from parish to parish, this process of who is pronouncing is an issue. And so one of the things I've thought of was also working with the Coroners Association and trying to come up with a unified process across all parishes. So that way it's the same for everybody, because our agencies are serving different parishes, and for staff to remember how East Baton Rouge Parish is working as opposed to East or West Feliciana or Ascension, Livingston, if you service all those areas. So I'd like to hear from y'all if anybody has had any issues lately with the pronouncement of death or complications. Or Jamie, if you would like to add to that.
Yeah, and if you would like to say something, you're going to have to unmute yourself. Everyone's been muted.
Mhm,
But what we're looking for are the issues that may have come up for you if, you know, um, it's a hodgepodge. It was proving to be a hodgepodge of policies from one parish to another, to another, to another. And whether the coroner goes out or the coroner releases the body over the phone, and who's he releasing it to, and what happens to the body, and who's actually doing the pronouncement. So there's a bunch of stuff that came up this past year. We have a new set
mhm,
of folks in the Department of Certification and Licensure, new surveyors, and the interpretations that were in place just 2 years ago are different today. And so we've had some folks being cited for the process by which death is being pronounced or death is being handled in the patient's homes.
mhm,
The other thing that we've been told is that LPNs are not allowed to do death calls. That this is a there's RNs are required, and part of that goes back to the federal standard that says that RNs have to be the ones calling in. And I'm not a nurse, but LPNs in the state of across the country in Louisiana, LPNs have expanded scopes of practice, but unfortunately, because of the federal law that limits the function and scope of practice for LPNs across the country, it's not being recognized because of the federal restrictions. So LPNs, my understanding, can only observe, record, and report. However, calling the coroner and reporting a death is outside of their scope of practice because LPNs cannot do assessments according to the federal rules. And the pronouncement of death would be an assessment. So, as they were explaining to us, LPNs would be secondhand knowledge as opposed to a firsthand knowledge, because the LPN would have been assigned by the nurse to do that, and that simply doesn't work for the surveyors. So, has anyone else been encountering confusion or difficulties with this issue in your jurisdiction, in your parishes?
So
Well,
can
hey, Jamie.
I
Lee, go ahead.
okay. So we had an experience and I worked for the hospice of Baton Rouge. I've been here for 20 years.
Uh-huh.
And I was a nurse out in the field before I'm in compliance and quality. And I mean, my experience has always been that when a nurse, either RN or an LPN, goes out to do a death visit and contacts the coroner, um, even if it has been an LPN, that has been accepted by the coroner in each parish that we've worked with. And so that, I feel like, that acceptance has, I guess, led to some confusion then when we are surveyed, and that is not acceptable to the surveyor. So I guess, Elizabeth, what you said is working with the coroners and coming up with I mean, that was
Mhm,
sort of what I was thinking is like, from that level, that would be helpful to come up with, who do you allow, since you're the
mhm,
coroners, provide the acceptance for that death verification
right.
so that they can pronounce.
Mhm,
What we're being told is that the federal standard excludes LPNs from even doing that. It can
Okay.
only
Well,
be it can only be the RN calling the
yeah,
coroner, not the LPN.
yeah. So I guess when the regulation is cited at the state level, they cite the state regulations uh for coroner and then for who an LPN can see and what they can do and what they can't do. The federal regulations weren't stated or cited there, but that would be helpful to
Mhm.
know. If you can share those with us, I would like to see that. I'm not
That's
sure of what
Okay.
those are.
so when they weren't cited, it was under when Marion Tate was the head of survey and certification.
Mhm.
Like I said, there was different interpretation by that administration. This administration is taking a different approach.
Okay.
And we have been in conversations with them and going round and round, but they are fairly adamant
Right.
that they're following federal standards, whereas we may not have been following those standards in the past.
Okay. I mean, I
Okay.
guess what I'm asking is whatever those federal standards are, if you know them or have them, can you share a site that we can review them?
Yes,
Yes.
they were brought to our attention,
Yeah.
and we can certainly I'll get the federal citing for us for the
Mhm.
next at least the next session that we have, if not before.
Thank you.
And Casey, I see your hand is raised.
Okay.
Hi, can y'all hear me?
Yes, ma'am.
Yes. Mhm.
So, um, there's an echo.
There is an echo.
Okay, how about now?
We can hear you.
I think you're good
Great.
now.
Thank you. So just a couple of things. There's an echo still. I am so sorry. Maybe I should mute and just place it in the chat box.
Why don't you put your on mute on your computer and just talk on your phone? You have to unmute your phone.
Mm.
No. When the technology works, it's really good. But when it doesn't work, that's the problem.
Oh, she typed it. Oh, can you
You don't have
unmute her phone?
it says ask to unmute. Let me, I can't unmute you. You have to do that. There you go. You're unmuted now.
Okay, thank
There.
you. I apologize for the troubles.
No
Um,
problem.
no, I really do have a lot of concerns about
Mhm.
this. So one of them being that everyone, is well aware that there is a widespread and ongoing nursing shortage. As we transition from his to hope, our staffing is going to be, stretched, you know, far thinner than it already is. A lot of folks, and I don't want to speak on behalf of, an organization that I currently work for or have previously worked for, but just kind of generalizing, I think a lot of folks have potentially utilized LPNs for the death visit um, because they're, that's an area where they can easily be utilized. And so it would never have been the practice anyway that the LPN was actually calling the time of death. They're observing the vital signs, reporting those either to the coroner or the physician on call, who then calls the time of death. And that has never been an issue where there's been a federal citation for any organization that I've ever, been a part of. So it's a little bit troubling to me that this is suddenly under kind of maybe some scrutiny within our state, knowing that. And so I'm wondering, is there any consideration to the difficulty with staffing now that we're transitioning to Hope that the state will kind of consider?
UDH has been very reluctant to consider our request. Let's just put it like that. If it seems to be, if we're going to change anything, we're going to have to change it at the statute level in terms of the legislature. I think the legislature is
Mhm.
going to have to get involved. Um, and also, we would have to get the Board of Nursing on board with this because I think the state is bowing to pressure from the Board of Nursing to clamp down on LPNs doing these death visits.
So then I do have a follow-up question,
Uh-huh.
whether this could be something that's, considered. So potentially creating for hospice in our states some sort of telehealth that is not billable but is maybe reportable, where the LPN, physically goes to the visit but does a telehealth where there is video and audio shared two-way communication so that they can report the observable lack of vital signs, but then also have that individual, that provider that they call, be present for telehealth. I think that could be a possible solution that wouldn't tie up the staff so much.
Yes. Well, telehealth, right now, the federal waiver allows us to do recertifications with telehealth, nothing else. You can supplement, but you can't use as primary telehealth for any visits. And I would think the death call is going to be a primary visit. I'm, I don't mean to be contrary, but I'm trying to interpret or give you what we are being told every time we approach this subject with either the state or with CMS.
Mm-hmm. Thank you.
Okay, yeah.
Mhm.
Look, I think that hospice nurses and LPNs I think they should be able to pronounce. Mississippi, an RN can pronounce, not an LPN, but an RN. We don't even have that in Louisiana. I think that hospice nurses should have that ability. But I'm not the governor. I'm not the state legislature. And we would have to get the backing of the Board of Nursing, because
Mhm.
they're going to be the first ones to oppose that change.
Well, and on that note, I don't think it would just be the Board of Nursing. I think we'd also have to work with the Board of Medical Examiners, the State Medical Society, and then the LPN Association also, if we're going with the anything relating with LPNs. So
The
there,
LPN board is on board with us. They want us to move forward with this,
yeah.
but it's but we're getting the pushback at the state and the federal level with regards to LPNs even being involved in reporting a death, let alone pronouncing a death.
Mhm. So as you can see, this kind of a workaround issue where it involves a lot of different groups, and so that's what we're trying to figure out how widespread this is. And it sounds like this is starting to become a bigger issue and might need to be towards the top of our list.
Has anyone on today's call ever been cited for an LPN doing a death call?
Or if you don't ever want to state that, you can email Jamie and I and also just
Yeah.
let us know too. So
That's the only way that we
uh-huh.
can take this. We have to know what's actually happening out there, and that's why we were hoping to.
Yeah, and knowing specifically what you were cited for and what it says really helps us with moving forward. Um, okay, so just to go ahead and move on, since it's been, unless anybody else has something to say on that issue, real quick.
So on that issue,
Mhm.
has anyone been cited on your procedures for pronouncing a patient deceased?
Um, so the next issue that I have is medication disposal. Jamie Dyer with the Department of Health also said she's seeing ongoing issues with this, and hospices not taking the medication or disposing of the medication on site. And I spoke with her about it, how the statute itself is very conflicting because the first part of the statute says that the controlled substances may transfer to the hospice, which means it does not have to. But then below that, everything else says shall. So when it says the hospice shall conduct immediate disposal of the controlled substance, that's really conflicting. And so we're trying to figure out how we need to address this. If we need to make it all say shall, or if it should all say may. Either way, it needs to be the same. I have had some people say it should say shall, so that way it's just the hospice has to take it, and that's very clear. And then I had other people who were concerned that if the hospice has to take it, and then there is arguments within the family and the home at the time, what do they do? And if they don't take it, will they get cited then for it? So my two questions are, one, has anybody been cited from the Department of Health for this recently? Or two, are you having any issues with this? Is it common that the family does not give you the medication to dispose of it? Or is it just not really an issue and LDH is being picky about it?
Has anyone had a family object to you disposing of the medications?
Hey, it's Nick.
Yeah.
Well, we got cited in New Orleans and Baton Rouge for medication disposal. I think, and we did IDR it, and we're still waiting in Baton Rouge. The surveyor we had in Baton Rouge is different than the one we had in New Orleans. One of them was the way we were doing our med destruction form. We used WellSky. So it's a visit verify thing. The New Orleans surveyor would not accept that as a signature that the caregiver, whoever, that was an actual witness because those meds were not listed on the form. So that's what we got tagged for in New Orleans. And then in Baton Rouge, we got tagged for, that surveyor was completely fine with the visit verify as the witness to the signature of the med destruction forms. But in Baton Rouge, we got cited for the med destruction form, as well as, but we'd already changed our form at that point because we got cited in New Orleans. But we also got cited on narcotic counts not being done at every visit, which kind of is also a very gray area when you read the regulations and everything. And what they cited on our 2567 was a governmental study from the federal level. It doesn't necessarily say that you have to count narcotics. And she kept using the word disposal, and I forget the term that I was trying to look at our 2567 because we're still going through it, but disposition she was using as narcotics had to be counted at every visit and documented. But again, the regulation that she cited us for was a governmental study that it was also for home hospices too, not necessarily patients in skilled nursing facilities. So she kind of edited the title of the article. But yeah, it seems like kind of like surveyor to surveyor. And
It's different.
And when she actually came back and cleared us for the one in Baton Rouge, she said that yes, if a patient refused to do it, it was the hospice's responsibility to call the cops and file a police report. And I've been doing this for 14 years.
Yeah.
I think I've had, one or two patients decline to give you the medication. So it's not a common thing, but
Okay.
she said it was our
Oh,
duty as
and Nick, if you
call the cops.
if you remember, before the opioid crisis was announced, CMS had an opinion where those medications belong to the patient's estate and hospice. Since Medicare bought it, the patient's Medicare benefit bought the medications, then they belonged to the state, and the hospice had to keep hands off. I remember when we transitioned to, we were destroying drugs, and then we were told you cannot. That's left to the family, and then we ended up with a opioid crisis, and then they wanted to clamp down on who had the responsibility of that. But it's been very confusing over the past 20 years in terms of how to dispose of these, how to dispose of the drugs. Pauline, you said, I'm sorry, it went off. Let me pull up the chat box.
And Casey also made a comment. May allows the hospice that leniency in those terrible circumstances where the family will not allow the hospice, but the hospice policy would be an attempt to do so. And I do agree with that. So there's pros and cons to both. So that's why we're getting everybody's opinion. Let's see, Pauline, you said we were told the same by LDH surveyor, but not cited for the requirement to call law enforcement if the family declined to authorize the disposal. And part of our concerns with that is that then leaves a bad taste in the family's mouth.
Oh my God.
It ruins the whole experience of bringing hospice in and what hospice was coming for. And last thing you want is during the time of death to make matters worse for everybody.
Exactly. Yes, a really critical time during the patient's death, and all of a sudden, you're informing them that you're going to be calling the cops because they don't want to give you their medications, and the law says they may, the hospice may take it, and then shall, and so, well, I think we will definitely need to get this language cleaned up in the state with the state
Right.
legislature. This is this is not a regulatory, this is a statute
Yes.
issue that has to be cleared up.
This one is in statute. In my personal opinion, obviously we have to take this to our board to discuss. It's not that, to me, the major issue is that it's the first part of it says may, and then the rest of it says shall. So it either needs to be one or the other. So, and we're going to have to talk with legislators about that as well on how to handle this moving forward in their opinions. Anybody else have anything to say on medication disposal?
Let's move to the next one.
I was just going to say, so what she had cited was the Government Accountability Office preventing drug diversion, disposal of controlled substances in home hospice settings. So, like I said, it was more of a study and a recommendation as opposed to
Right. They're not a regulatory or in law enforcement,
Yeah.
because
Correct.
the DEA gives a different opinion. All these different enforcement agencies are giving conflicting opinions, and that's part of the problem. But the state legislature, if they would clear up their law, then we would simply follow, because we always have to follow the most stringent, whether it's state or federal, and that would be the most stringent to take control of those drugs upon death.
Mhm. Okay, so the next issue deals with staffing issues in reducing the requirement for nurses. Currently, it's nurses to work in hospice have to have 2 years of full-time experience. And this was waived during the pandemic, but now it is back. We have talked with the Board of Nursing, and in the past, they have not been willing to reduce this. And we are hearing from our agencies that staffing is still an issue with nurses. And so is anybody still having nursing issues? Would you be in support of reducing that requirement? Um, Anybody have an opinion on that?
Absolutely. It puts a damper on trying to hire nurses, um, waiting for that time that they have to be out in the field. So it would definitely help us out if I didn't have to follow that.
And Laurie, and at the end of today's program, we have a poll that we're going to ask everybody to fill out. It's just 10 questions covering all of these subject matters. But one of the questions is, do you support keeping it at 2 years, reducing it to 1 year, or should there be no previous hospice experience required?
My opinion
Mhm.
is no hospice experience required. That's my opinion.
Make sure you mark that on the poll because that's what we're going to use to with the board in terms of what we're hearing. But we want to hear from you all. Is anyone else having difficulty hiring nurses, RNs?
I would think that's probably all of us.
Okay.
I mean, or you get them hired, you know, and they're not long term. So it's, yeah.
There's a lot of turnover we're hearing with nurses, with staff in general. Is that true?
Definitely more than I've experienced ever.
And let me ask you, while we're on the subject of staffing, what about social work? What about chaplains? What about CNAs? Are there any other, aside from RNs, are there any other disciplines where you're having difficulty staffing or keeping staff?
For us, it's definitely our New Orleans location, and it's definitely our home health aides and our, not really so much our RNs, but I mean, definitely our home health aides here, and then in Mississippi, it's more of our RNs finding, you know, dedicated staff.
We have Mississippi coming up another day. We're just focused on Louisiana today, and so you're saying there's difficult to find CNAs in some markets, right? Not in all the markets.
I would say like quality CNAs that, you know, are great in an interview, seem to have personality, have the hospice story, you know, have a good background, have good, you know, work history, and then you know, I think a lot of times, and that's always the big struggle, right? Is you're in a hospice, you're going into home settings, people get all this freedom and they can't really adjust to it a lot of times. So for us, it's been more so in the New Orleans locations, it's finding kind of good CNAs, quality, and keeping them.
Thank you. That's good to know. Anybody else with regards to other staffing members of your team? Difficulty. No one's having difficulty finding a social worker or chaplain or CNAs other than perhaps in the New Orleans market. Okay.
All right, then let's see. Our next topic that I have is private insurance coverage for pediatric concurrent care. And Jamie, I'm going to let you take that one.
We recently had a case where a child who had a terminal or a serious illness. I'm not going to say terminal illness, but they had a serious illness, and concurrent care would have been indicated if they had been in a Medicaid program. But because they were with a private insurer, the private insurer was not allowing for concurrent care. which I was surprised at. I thought the Affordable Care Act said that kids could get concurrent care, meaning that they could get curative care as well as palliative care when we're dealing with something a very serious or terminal illness. Um, so the rules were kind of different for pediatric hospice patients than they were for um, but we were told by insurance company that they didn't have to follow that rule. It's like, oh, okay. And we were wondering, has anyone else run into this issue where private insurance was refusing to cover pediatric concurrent care? So this was just a one-off. This was an anomaly. This is not something that you all are seeing out in the community right now. Okay.
I guess. All right. The next issue is perinatal hospice care. This seems to be kind of a growing topic that's being talked about. In 2024, during the regular session, there was a bill passed that has LDH to create a informational document to be made available to pregnant mothers following the diagnosis of a fetal abnormality. And on that document, they would like hospice providers that provide perinatal services to be on that list. Um, as of today, I check regularly on the LDH site and ask around if anybody has received this document or seen it. As of today, I do not believe it has been created yet. But from our standards, we want to know how many of our hospices are providing these services. If any, how many are doing it in the home, or is it mostly in the hospital? I assume for the most part it's done within the hospital. I have heard of a few that do it within the home settings. But we also want to make sure that there is kind of a equal standard of care for perinatal services, that from hospice to hospice, it is the same. And then moving forward from that, as of right now, there's no reimbursement for this. And also, how are you billing for it? Because technically the baby is the patient, but the patient isn't born. So you're seeing the mother. We're trying to understand all the ins and outs of this. And then also with that document, it was discussed that there should be um, a separate listing for palliative care as opposed to hospice care, because we don't want someone going in that is a patient looking for palliative care, and someone's talking to them about the death of their child. Just so it makes it easier for the patients to understand as well.
So is anyone on today's call offering perinatal care in their community? One of the issues that we raised with Right to Life, who was the author of this bill for perinatal care in Louisiana, was there is no reimbursement, and they were kind of like, "What do you mean there's no reimbursement?" And it's like, "Who's going to pay for it?" And they said, "Oh, we didn't think about that."
But they
So,
did say that they would like to have a discussion about that moving forward. So,
mhm,
that's part of what we have to develop.
right. If there was a reimbursement for perinatal care, how many on today's call would say we would be involved in perinatal, would be willing to be involved with perinatal care?
I would be willing to do that down here, South Louisiana.
Anybody else? Okay, go to the next.
Um, so the next issue I have, this would actually be for Mississippi. It's about the Mississippi hospice
Yeah, well, let's pick
moratorium.
that. Let's
So
pick that. Yes.
we'll skip over that one. But for anybody who just wants to know, in Louisiana, we have a facility needs review that is done by statute. So that is in law, and we do not have to go and reevaluate that every few years like Mississippi does. Knock on wood, at least right now we don't. um, Medicaid. Jamie, you want to touch on that one?
Yeah, I'm just wondering, is anyone having a Medicaid issue right now? Is there, I know that there's delayed payments and things like that, but is anyone um having an issue with having a Medicaid issue that you would like us to uh look at as with the for possible solutions or resolutions? If it's a matter of payments being delayed by 30 or 60 days, that's one thing. But I mean, if we're talking past 60 days, that's a real problem. Anyone having those types of issues right now? Anyone having an issue with Medicaid managed care providers? You know, the CMOs. You're being paid on time, correctly, and what you were hoping to be paid. Well, that's pretty good.
Mhm.
Okay.
All right. And then the last issue that I have on my list, Jamie, is opioid regulations.
Yes. Or is anyone
Mhm.
having an issue aside from the medication disposal issue? Does anyone have an issue around the use of opioids? Either you're having problems getting opioids, or you're being cited for the use, or your doctors don't want to prescribe, or any type of opioid issue that you are currently having with your agency or patients. I know there was one issue in terms of ketamine, whether or not uh,
Oh,
the
yes.
I know that Dr. Nelson is looking into the expanded use of ketamine in the state because there's something that was prohibiting.
Yeah, I'm not sure the technicalities of it. I do know I spoke with another doctor. She's been kind of reaching out to different groups in the legislature about ketamine being administered during the end of life. As far as I know, it hasn't gone anywhere yet. She was trying to create a study committee, and I did ask her to include us in that or advisory council to do a study on this. And so I did ask her to include us in that. And I've talked to her multiple times, but I don't think it has gone anywhere with the legislature as of right now.
So I know in the inpatient setting, they basically the hospital, St. Tammany Hospital, has decided that we could not use it on the floor. The patient had to be in ICU for some reason. So I have not really used it for that particular reason.
It's very restrictive. The requirements around using it are very restrictive, and I think Dr. Nelson has taken it to the Serious Illness Coalition and part of the palliative care uh, advisory group. And so we were just wondering if you all could give us some sort of insights as to the use of ketamine with your patients and if you're having any issues around that.
Yeah,
I'm
as I
just,
said, I haven't been able to use it because they require that we have the patient in ICU, and of course the hospital doesn't want us to use an ICU bed for hospice patients. So that's one of the reasons why I haven't been able to use it.
My question would be, are you interested in maybe using it in the future?
Yes, yes,
yeah, yeah.
certainly.
Yeah.
It's
Okay.
it's an incredible, especially effective, I understand, for nerve pain.
Yes, yes,
Mhm.
yes.
Yeah. Anybody else? Okay. Do you have any other issues?
I do not have any other issues,
Okay.
unless our members have other issues, and then we have the
That's where I
poll.
was going to go. Does anybody on today's call have an issue other than what we have discussed so far? An issue that's not being addressed?
I don't know if you remember, Liz, when we went to DC, there was an issue about whether a patient can be admitted to from the hospital, a patient that is hospitalized and being transferred to hospice. For example, if they have no family to take care of them at home, if hospice can be provided like in the hospital setting until we can figure out what to do with the patient, like for example
Mhm.
respite or something like that.
Uh, I think some hospital palliative care units or have like a mini inpatient hospice section that they're
Yeah,
using for
well,
precisely those patients.
there is an inpatient, but if they don't meet criteria for inpatient, for example, can they be admitted to respite, for
Mm.
5 days while everything is being, decided
Yeah,
on? Some of these patients have no family and they cannot go back home, and there's no one to sign papers for them to go in a nursing home or something like that. And a lot of times we have to wait for a while until the situation can be resolved.
right, right. And I know that there was an incident recently where we had somebody that needed more than 5 days of respite, and the only solution that we came up with was that uh, there was one day where the reimbursement was going to be routine home care, and then they could put them back into respite after that one day. But there was, you
Oh, I see. Yeah. Or
do
at least,
it'd be 5 days of respite, one day of routine home care, and then another 5 days of respite because the situation was not resolved. And that was the only solution that Palmetto was willing to
mm,
advise us of for that particular patient. So
okay.
there are workarounds, but they're sort of clunky.
Okay.
So we need to work on a easier workaround for that.
Yeah,
I have
and
that written down.
respite should be one of the. But again, that's going to be something that's going to come from the federal level. CMS has to allow that. That's not
Mhm.
state. That's not a state statute.
I see.
Okay. I have that written down though as something to start working on.
All right.
Anyone else have any other issues that you'd like us to pick up?
Can you get your social worker board to allow easier reciprocity between states?
Say a little bit more about that, Nick, in terms of what's not happening.
No, like so it's easier for you social workers to get licenses in different states. I don't think it's
That
really as
did not get, that didn't
complicated.
get passed? I'm gonna have to look that up because I do not know. I do know that there's been multiple bills of all different, licensures that where they've been trying to do reciprocity across states. So I will pull that one up. If it did not pass, I would imagine that that will be coming in this session, and we can look at helping them and supporting them on that.
And is social work included in the compact agreements? You know, I know under
They would have their own separate compact agreement, believe.
social work would have to have that. Okay.
Unless you know more about that, Nick, or have heard anything different. I believe they have each board has to have their own compact agreement.
Correct. That's from my
Yeah.
understanding.
That was and I'm sorry, I thought that had been passed, but I will look into that.
Well, yeah, I know it was brought up last year and everyone was kind of excited about it, but then this year at the conference, I didn't necessarily hear anything and I haven't necessarily seen anything. And I asked
Okay.
One of our kind of lead social workers, she also works for Oshner, and she did not think that anything had passed yet.
Okay.
Okay.
That's
I'll
what
look into that more and get back with
Do
you on
some
that.
digging on that one.
Mhm.
Any other issues before we throw up and launch our poll with regards to all of these questions? We want to get you, please, it's anonymous. You won't be putting your name on any of this, but we do need to get some feedback from you, some data from you, and get your opinions. So if there's nothing else, I'm going to go ahead and I'm launching this. You should all see a poll.
I see mine.
You see yours?
Mhm.
So what we're asking you is to rank which issues are top priority, medium priority, low priority, or no priority. And then answer the other questions. The others are yes, no, not sure. But they're asking you for specific examples. Folks, only 2 people are completing the poll. Come on, we need everybody to participate in this. We want your thoughts. 4 out of 12. 5 out of 12. Thank you. Thank you, number 5. Can we get 6? Can we get a 6th person? There we go, 6. Now that we have 6, we can get a 7th.
Jamie, this is Cord. I'm out of state, so I won't do a poll. But
Thank you.
wow, am I proud of you from your research expertise in getting a Zoom poll and then encouraging people to do it. Outstanding.
It was a first. It was a first for us to use this poll that Zoom actually provides, and so we're going to.
I love it.
Yeah, thank you, thank you. Yeah, I did too. It's easy. It's very easy. So that's why we want as many people as possible to please complete this so that we have a record. I think that's going to be because you're Cord, you're 10, Elizabeth, you're 11, and I'm 12. So, but we have 4. I'm sorry, we have 14 people on. We have two more people, so I need at least one more person to complete the poll before we
Well,
sign. We
Casey
have
is
one more
also
minute.
two.
I'm sorry?
Casey is two because she
Oh,
called
that's
in
right.
from her
That's right.
phone also.
That's right. That's right. That's right. You all are correct. Okay.
Yeah.
Is everybody? It
Mhm.
is 11 o'clock. We are finished. I want to thank everybody for your time today. If you have any thoughts, we will be repeating this session next week. If you have any thoughts
Mhm.
between now and then, please send them to Elizabeth. Elizabeth, you have your email in the chat box, correct?
Yes.
And
My email and my phone number. And if you ever want to add on anything, please send it my way.
And if you lose that, you can always go to the website
It's on.
www.lmhpco.org, look for the Alliance tab, look for state directors, and her contact information will be there. Always there to help you all with your issues. So I want to thank everybody, and we will see you all either next week if you join us, if you have new issues that you want to present, or um,
Mhm.
thank you.
Thank you. All right, Jamie, I was staying on until everybody was off, but I'll see you later. I think it went
Okay.
great.